T-cell lymphoma, they're a group of non-Hodgkin's lymphoma affecting mature T and NK cells. Just to give you perspective, there are over 80,000 cases of new non-Hodgkin's lymphoma projected to be diagnosed in 2024, of which only 5 to 10% are T-cell lymphoma. So not very common, just a few thousand new cases per year. However, T-cell lymphoma, they're also very complex. There are over 30 to 40 different subtypes, depending on where and how they're derived. If the process primarily involves systemic lymph nodes, secondary lymphoid organ like spleen, bone marrow, blood, they're grouped into peripheral T-cell lymphoma, PTCL. If it's primarily affecting skin, they're grouped into cutaneous T-cell lymphoma, CTCL. For peripheral T-cell lymphoma, PTCL, the most common symptoms are related to the enlargement of lymph nodes or secondary lymphoid organs such as spleen, reduced blood counts such as anemia due to the growth of lymphoma. Abnormal T cells are also very active immune cells that they secrete cytokines and cause immune dysregulation. So patient can present with fever, malaise, joint aches, and rash. For CTCL, the predominant presenting symptoms are either rash or discoloration of the skin in the form of papule, plaques, or raised nodules. The diagnosis for T-cell lymphoma, it's very complex and it's very important, actually the most important step of taking care of patients with T-cell lymphoma. So we recommend to work with medical oncologists and hematopathologists who have a lot of experience and expertise to initiate a very comprehensive workup. The diagnosis always starts with having a good tissue biopsy. So for PTCL, that involves getting a lymph node biopsy or soft tissue biopsy. Sometimes bone marrow biopsy could also be helpful. For cutaneous T-cell lymphoma, then a good skin biopsy would be required. And what do we do with the diagnostic workup? We look at various characteristics of those biopsies. So that involves morphology, cell biology with cell surface markers, and genetics, and molecular biology with mutations. For example, we want to know what kind of surface marker are those T cells expressed. Do they express CD30, for example, which is uniformly characteristic of an anaplastic large cell subtype? And what kind of cell of origin is the T-cell lymphoma derived? Are they follicular helper T-cell lymphoma, which is a new entity but really unify previous multiple subtypes, including angioimmunoblastic T-cell lymphoma? And then we have more advanced sequencing technology, next generation deep sequencing, which allow us to know what kind of specific mutations that comprised for this particular tumor. And those mutations not only help us to refine our diagnosis, but sometimes they can point towards a better treatment. For example, the follicular helper T-cell lymphoma has recurrent genetic mutations in epigenetic modifying process. So knowing that, we may think about using agent, targeting epigenetics for those subtypes of patients with T-cell lymphoma. So in summary, I think that the comprehensive workup really gets to a very clear, in-depth understanding of the subtype and with some knowledge of the biology, which help us to come up with a comprehensive management plan for this patient. So frontline treatment for T-cell lymphoma is actually a very active area of research. Historically, PTCLs are treated, use one-size-fits-all kind of approach, using chemotherapy primarily, such as CHOP. It's not specific, and obviously it did not work very well for majority of the patient with T-cell lymphoma. And now that we have more refined classification and to the resolution that we know what are the surface marker of this T-cell lymphoma, where are the cell of origin, and what kind of prognostic or pathogenic genetic mutations am I contributing to the T-cell lymphoma. This really allows us to do a more personalized match of new treatment that's specific for the underlying pathology of those type of T-cell lymphoma. So with that, we hope we can provide better tailored and matched treatment for various subtype of T-cell lymphoma. Just to give you an example, for CD30 positive PTCL, one of the representative is the anaplastic large cell lymphoma. We use now a new frontline therapy, which use a antibody drug conjugate called brentuximab vedotin, BV. BV plus CHOP-like backbone CHP is now the standard of care of the frontline therapy for CD30 positive PTCL. What about not CD30 positive PTCL, other subtypes? There are multiple research studies ongoing. One example is a intergroup national study. It's randomized to add novel agents to the CHOP-like backbone. So those novel agents including a epigenetic agent, hypomethylation azacitidine. The second new agent is a PI3 kinase, duvelisib. So comparing azacitidine plus CHOP versus CHOP alone, or duvelisib plus CHOP compared to CHOP alone. So the overarching efforts is really to see if our precision diagnosis of peripheral T-cell lymphoma and that matched with a new agent that target the biology could we bring a better outcome for our patients. There are a number of very promising new approaches for patients with peripheral T-cell lymphoma. We generally testing those approaches in patients with recurrent disease of either peripheral T-cell lymphoma or cutaneous T-cell lymphoma. I would say, there are at least three large categories. The first one is epigenetic targeting agent. Those are to modify DNA, their methylations and histone methylations, deacetylation. The second large category is target pathways such as T-cell signaling pathway. They are important enzymes along that pathway where we have inhibitors. And the third large area is to attack the interaction of the tumor cells with its tumor microenvironment. So I want to give you some examples of each of that. For example, the epigenetic targeting agent, we have HDAC inhibitors. They are romidepsin, belinostat, and they're actually used in care of patients with relapse resistant peripheral T-cell lymphoma and cutaneous T-cell lymphoma. They're also being evaluated in combinations with other agents. The other category for the epigenetics is hypomethylation agent. One example is azacitidine, and it is being evaluated as a single agent in combination with other novel agents or chemotherapy. And the newest agent in that particular category is IDH1/2 inhibitor, which essentially targets histone methylation. And one such example is vilometostat. It's a very new agent, but it has been studied in phase 1 and phase 2 study. We are really looking forward to know the final result, and we hope that those new agents will be made available for us to use for our patient with very difficult to treat form of peripheral T-cell lymphoma. Some examples of the second category, which are the T-cell signaling pathway, and they could be PI3 kinase inhibitor, such as duvelisib. We also have JAK-STAT inhibitor, especially JAK inhibitors. One of such is ruxolitinib. It has been studied as a single agent, also in combination with other agents as well. Finally, there are really cool stuff for targeting the tumor and microenvironment interaction, they tend to be immunotherapy. They're manipulating the immune interaction, such as immune checkpoint inhibitors, by specific antibody that try to link the antigens of the tumor cells with immune cells, or sometimes, T-cell specific CAR Ts. They're clearly in fairly preliminary stage of their clinical development, but we're really looking forward to their possible potentials. So in summary, I'm very excited with all those new agents, and we hope that by knowing the biology better with precision diagnosis and have more availability of those novel agents, we will do a better job in terms of match and tailor our treatment to specific subtypes of T-cell lymphoma, such that we can provide better effectiveness but also reduce side effects for our patients.